The question is that this House do now adjourn. Mr. Stephen Barclay.
Thank you, Mr. Speaker. In the wake of the Francis report and the news that 14 more trusts are under investigation due to unnecessary deaths, it's clear that our current system of healthcare regulation has failed. More importantly, this has meant the NHS has failed its patients, and the Care Quality Commission is clearly not fit for purpose. I have seen documents suggesting 25 hospitals with abnormally high mortality rates were highlighted to the then Secretary of State, the Right Honourable Member for Leigh, in March 2010. 7 of the 14 trusts now under investigation were on that list. He referred them at the time to the CQC, which confirmed it had, and I quote, "no current concerns about these trusts which would require intervention." Yet some of them have had high mortality rates for over a decade. Sir David Nicholson tried to paint mid-staffs as a singular case. Minutes of meetings imply that the concerns of patients' families were dismissed as simply lobbying. Perhaps more worryingly, it would appear there's not just incompetence, but a culture, Mr. Speaker, of cover-up within the NHS. Let me give you just one example. Professor Sir Brian Jarman, a world-respected authority on mortality data, has raised with me allegations of trusts fixing their mortality figures. In essence, trusts relabelled deaths as palliative care, after the definition was widened by the Department of Health in 2007. When this was done, the hospital's standard mortality rate would fall, as those palliative care deaths were considered normal and not down to poor care. Experts suggest that a figure of around 4% of deaths should be classified in this way. Yet at Medway, one of the trusts now under investigation, it jumped, Mr. Speaker, to 37%. It suggests in 1 month the hospital had been transformed, not so much from a hospital, but more into a hospice. This paper reclassification improved the hospital's mortality scores by around a third, yet nothing had actually changed on the wards itself. In other words, they were fiddling the figures, and as a result, masking poor care. The same tactic was used by mid-staffs to obscure what was really going on, and the number of deaths classified even now as palliative care across England is still higher than should be expected, and it's higher than comparable international countries. So this minister needs to be looked at urgently. Until it happens, we cannot be confident that the 14 now under investigation, 7 of which we were told were not of concern in 2010, that those 14 are all that we need to worry about. And perhaps more distressing is that management consultants actually profited from masking the real causes of these deaths. The CHKS Advisory Group visited hospitals to advise not on how to reduce mortality and save lives, but on how to make the figures look more normal. With pleasure.
I thank my honourable friend, who is a very respected member of the Public Accounts Committee, and I'm sure he'll know from the work he's done there that target-driven culture, in whatever department of government it might be, can often lead to anomalies and inefficiencies. Is it not extremely worrying, and is it not a matter for the way that those targets are framed in this case, and the way that he's highlighting, that these targets are leading not just to inefficiencies, but to actual loss of life? And would he suggest that it's not just the individual hospitals that he is naming and listing, but the entire target-driven process that needs to be re-examined by the government and the minister?
Well, my honourable friend is absolutely right. These deaths, in part, led from the target culture. It's not that the targets were set with that intention, but that was the consequence. And what we have seen is the fiddling of figures to meet those targets. And what we're going to ask is about the people who were responsible for that. So between 2007 and 2009, the chairman of the advisory group at CHKS was Niall Dixon, not a doctor, a journalist. And he's now the chief executive of the General Medical Council. So the minister I hope, in his remarks, will address whether he has reviewed the role of CHKS in advising hospitals on how to reinterpret death rates, and whether such a person or involved in an organisation like that is the right person to be regulating doctors today. There is, Mr. Speaker, not surprisingly following the Francis report, a flurry of activity to explain what new systems will be put in place. But as an ex-regulator, I know that such changes, whilst introduced in good faith, are likely to be flawed. If we are to ensure patient safety, we need a culture change. The ultimate regulator is a well-informed patient. The ultimate inspectors are whistleblowers on the ground. All we need is quality, transparent data for patients to be able to make real, informed decisions about where to be treated and how to hold the NHS to account. It's remarkable, Mr. Speaker, that a report last week said that 2/3 of doctors and nurses at some hospitals will not recommend their own hospital to their family and friends. What does that say about the regulation of those hospitals? It's common knowledge for NHS insiders that certain doctors are good and certain doctors and surgeons and hospitals should be avoided. But why should our patients be kept in the dark about that sort of information? Projects like the Dr. Foster unit at Imperial are world leaders in providing health information. And the decision to publish heart surgery outcomes was very welcome. But that status quo simply does not go far enough. We have today data available privately which shows outcomes broken down by hospital, department, ward and even individual doctor. And I urge the Minister tonight to start to make that public. This data has never been published. Those within the profession know what it contains. It's time we trusted the public with the truth. Of course, it's got to be presented in a meaningful way, but there's a duty to explain it, not to hide it. We've seen with heart surgery what a positive impact such transparency can have. But I ask the Minister just to reflect on one point. We now have the safest heart surgery in Europe because, in part, we have data transparency. But this is down to the consultant anaesthetist Steve Bolson. He was the individual that exposed high death rates for child heart surgery, which was published then in Private Eye. This in turn led to the public inquiry, and the publication of the figures has clearly driven up standards. But it was a whistleblower that was the impetus for this change. It wasn't the Department of Health, it wasn't the Royal College of Surgeons, it was someone prepared to speak up. And incidentally, isn't it revealing that he no longer works for the NHS?
Will my honourable friend give way?
With pleasure.
I thank my honourable friend for a very, very powerful and informative debate. Would he agree with me that it's not only making sure that data is transparent for patient groups, but also we've seen a failure of the quality of assessment, that hospitals that have obviously high mortality rates, even before fiddling the figures, have been deemed acceptable by our assessors? And would he agree with me that one of the reasons for this is that people who are not necessarily qualified to know the ins and outs of exactly what's going on, for example, in an operating theatre, are going around, ticking the boxes, saying that's all fine, when in fact it isn't? And if you had an expert eye of another experienced clinician in that field doing the assessment, very different outcomes would arise, which is why people like the Royal College of Surgeons were commissioned to do invited reviews, because they contained that knowledge and expertise.
Well, my honourable friend is absolutely right. If you look at the Care Quality Commission, a lot of the people doing the clinical assessments are not themselves clinically trained. And even when they do have a clinical qualification, often it doesn't relate to what they're actually looking at. So we have doctors going in to look at baby units. And likewise on coding, the point my honourable friend makes applies as well. We often have people reinterpreting the coding who are not clinically trained. And that's some of the media reports that we've seen in the last week. I want to move on, if I may, Mr. Speaker, to the issue of whistleblowers. They have a unique vantage point in terms of what's actually happening with patient safety. Yet, for too long, we've had a hypocrisy where we've lauded their contribution publicly while silencing or gagging them in practice. The Commission for Health Improvement found problems at mid-staffs back in 2002. A peer review by the Strategic Health Authority of critically ill children criticised mid-staffs in 2003 and 2006. Whistleblowers at Mid-Staffs raised concerns as far back as 2005, yet the warning signs were not acted upon. Many members of staff simply chose to close ranks. There appears to be a bullying culture which discouraged people from coming forward and where those that did were threatened. As one nurse at Mid-Staff summed up, the fear factor kept me from speaking out. This, Mr. Speaker, is not an isolated case. Even the Care Quality Commission, I mean, it's almost beyond parody. The Care Quality Commission, the body to which whistleblowers might turn, itself used gagging clauses. It disgracefully smeared Kay Sheldon, a member of the board of the Care Quality Commission, with the courage to speak out, and it was suggested she had mental health problems. That is the culture. And as my honourable friend, the member for Bristol North West, pointed out at the Prime Minister's questions last Wednesday, 3 reports commissioned for the 60th anniversary of the NHS that identified problems appear to have been buried. One of these reports, the US reports, in 2008 to Ara Darzi, stated, and I quote, a shame and blame culture, and refers to fear pervading the NHS and at least certain elements of the Department of Health. Why, I ask, were these reports buried? Figures I obtained after a 2-year battle in Whitehall showed £15 million of taxpayers' money being spent over 3 years to gag whistleblowers. Why are we spending £5 million a year of taxpayers' money to silence those brave enough to speak out? And we hide behind a guidance that says, well, the Public Interest Disclosure Act protects them. But as we've seen with the Gary Walker case, what happens is trust lawyers threaten and intimidate whistleblowers, even though they know that the Public Interest Disclosure Act actually gives them protection in practice. So I very much welcome the Secretary of State's recent letter, but I point out such clauses have no place in the NHS today.
Thank you, Honourable Gentleman, for giving way, and thank you for bringing this matter to the House as well. Very important issue. Does the Honourable Gentleman feel, while the mortality levels are at the highest in the NHS that they've been for years, the restoration of public confidence in the NHS is very imperative as well? And what steps does the Honourable Member feel that government should take to ensure that the public confidence is restored and people feel that there isn't the same danger in going to the hospitals and the constituencies that they represent?
The answer to that is to tell the truth. Because the public actually know. When I have constituents come into my surgery, as I'm sure come into his, and they talk about going in to see their husband of many years who's naked from the waist down, or taking soup in to feed them. They know there's issues, so let's be candid about that. There's many things that are wonderful with our NHS, but let's not hide where there's failures and there's concerns, and have a culture of cover-up that silences the whistleblowers who speak out. And so I ask the Minister, will he take this opportunity in respect of the official NHS circular from 1998, which states, and I quote, "It is not contrary to the Department of Health's policy for confidentiality clauses to be contained in severance agreements." Will he make sure that that is now scrapped? Because the letter from the Secretary of State does not force trusts to take that action. And I think it's high time we made the position on gagging clauses clear and beyond doubt. In conclusion, Mr. Deputy Speaker, what's clear is that regulatory failure across hospitals nationally shows the need for greater data transparency so that we can see the true patient outcomes and protect those with concerns among staff who speak out. This will secure a higher quality and safer NHS for patients across the board. We need to move the health service out of a cover-up culture and into the light, and to ensure individuals are held to account. To quote the Prime Minister, sunlight is the best disinfectant, and that applies on our wards as well. It's best that we have well-informed patients and staff able to voice their concerns. What's clear at Mid-Staffs, at the 14 hospitals under investigation, at the 25 highlighted to the Secretary of State and not acted upon, and the many other concerns we see around the country, is that clearly hasn't been done to date. I hope the Minister will be able to reassure us that he will now speed up action on these issues.
I call the Parliamentary Under Secretary.